So yeah, I really enjoyed looking at the fishbone diagrams, and it reminded me just to think about our longer journey of improvement. So this is a really wacky, busy slide, but it really involves the steps in our journey. And you have done a lot of work to date, just thinking about what are you trying to accomplish. And remember when way back when we were talking about the measures and talking about A1C and poor control, we know that there's a system behind that goes on in your site that creates the circumstances and the workflows and all the things that happen with the patient, that how you have it currently designed is giving you a certain number that Tina just showed us on those graphs. So when you identify that that performance isn't what you want it to be, you start your journey. So you identify these opportunities. Maybe you want to improve screening for depression or that A1C. And these are the steps that we've asked you to take. These are quality improvement, evidence-based best practices, and this is what you've been doing. So I thought I'd just show you, you're well along on your journey. So this is great. So you've created your aim statement. You've got your team set up, you're meeting regularly. Many of you are now collecting data on a routine basis. You've set goals for your measures. You're starting to think about impact, like Christina mentioned. You know, each percentage of a person that doesn't get screened for depression isn't just a percentage on your chart. It's a person that you want to serve in a different way. We've asked you to put those things together in a charter, which you've done, which really gives you a handle on the things that your organization is focused on in population health. And next we move to the theory of change. What do you think would make a difference in your system so that you can improve the care that you're currently providing? And we talked about the root cause analysis. We've also in previous calls talked about workflows, and you know, this comes out in what you tell us in the narrative. You're very aware of looking at the way that the work flows through your clinic and who does what and by when. All of those things make a big difference. And because you are looking at these things, you're beginning to gather some data. And we're going to talk a lot more about that data today. What we're going to cover really is, if you follow this, I couldn't fit it on one slide, so I had to go round about here, is how do you look at all of those root causes? How do you make sense of what to do first? And today we're going to go through 4 different tools. They're listed there, and I won't say them now because we'll talk about them later. And that's going to give you another idea of where to get started. Or if you're already started, what are some other things that maybe perhaps you haven't tried before that might be helpful to improve performance? And then we ask you to use that methodology that I know you all know and love, that Christina taught you, the PDSA, Plan, Do, Study, Act, and to implement some of those changes. And then now that you're collecting information, you're going to see the impact of the changes that you're making. Is it improving your system the way you thought it would? That's what those blue arrows, those cycled arrows, sometimes you don't get it right the first time. You think that something is really going to make a difference when you try it, and it doesn't move your dots. So we know that there is, it's science, but it's also an art, and it's also persistence that sometimes we have to figure out, because these systems are so complex. We can't always choose one thing to focus on. Sometimes it's more complicated than that. And eventually what we're hoping to see, of course, is that your improvements are achieved, your system improves, and you're really demonstrating that value. This is what value-based care is about, demonstrating the value that your care brings to the patient. So this is all tied into what's happening in your state, and you are very well along the journey. We're going to come back to this periodically just to remind us that it's a journey, not just a one-time stop. Let me see if I can get my slide to move here. So this was a screenshot from last webinar. I thought it was, I loved it. It was beautiful, but look how busy it is. Look how many ideas you came up with. And that really got us thinking about when you have so many ideas, how do you sort through those? So that's really the content area that we're going to focus on today. And remember that we are looking for the root of the problem. One thing I thought of is now that you have your fishbone diagrams, some of us probably have started down a different road. Some of us get an idea, and often, and again, I'm a physician, so I get blamed for this, probably rightly so, where the loud physician says, this is what we need to do, and you go down a path and you decide you're going to change something. Well, it may not make a difference at all. So what we're really trying to think about is this is an educated hypothesis of where we should focus, but it's not the be all and end all. So if we look at our fishbone diagrams, we want to look at them with a certain lens. So the first thing I think is useful to think about is we want to make sure that any of the causes that we see are aligned with our organizational values. And we also, in part, there should be in your charter, do you have any guidance from your leadership? The most common guidance I hear is, we don't have money to hire staff, so whatever you do, make sure that it's with existing staff. And we also don't have any money to get any new equipment or anything really fancy right now. So make sure any of your solutions to improve this work doesn't involve any major expense. And that's okay. Maybe it's not ideal. If we all had money trees, maybe things would be different. But doing this work in a scientific way helps us discern what are those things that we can make a change about and not worry about those things that are off the table. The other thing I can't emphasize enough is including the people who do the work. So we use the word team a lot, and I want to specify that for the purposes of these tools that we're going to describe, gathering the people that do the work around the measure, the system that you're trying to improve is important. So if you have a quality improvement team, that's great. They can definitely and should have input. But it's really, if you're working on the improving screening for depression care, you really want to involve the people who do that work. If your front desk person is involved in scheduling, whoever does the screening, maybe it's a medical assistant, maybe it's a therapist, you want to involve the people who actually do the work of the system that you want to improve. And we're going to ask you in your homework actually to gather that team and just get a feel, if you haven't done it that way before, just the discipline of getting those multiple opinions and see how it changes your results. It's pretty interesting. And the goal is to work toward consensus. And most of you can achieve that, especially with these goals, these tools that we're going to be sharing. So these are 4 tools. It's not by any means all of them. I'm going to be asking you if you've used these tools before. I bet many of you have, but we're going to go through 4 today: nominal group technique, force field, interrelationship diagram, and a check sheet and a Pareto chart. So we'll get started with those. So the first tool is a nominal group technique. This helps the team come to consensus very quickly. It's really good for teams that are new working with each other, or teams that have dynamics where there are 1 or 2 loud voices and a couple of people that don't say much at all. Although you know they're thinking, but they just don't talk very much. It is done individually, so you will see how much agreement is with the teams when you look at the tally. So you can see what level of agreement you come into the tool with. And you can also ensure that everybody feels like their voice was heard. Again, that loud voice versus soft voice, it's really helpful to get the buy-in when you want to make changes, when you have come to the decision of what to do by a very equally participatory process. So we're going to go through this. I just want to show you what one looks like, the output, and we'll go through how to do it. So basically, you're going to look on the x-axis, you're going to look at all the members of your team. Again, these are the people that actually do the workflows that involve whatever you're trying to measure, like depression screening. And then you're going to look at all of the root causes that you came out with. And every person is going to be able to determine from their own perspective how important it is to work on that particular cause right now. So let's just go through how to do this. So it's good to have a flip chart. I think most of you do that, or a whiteboard. If you already have done a fishbone, you've done a lot of the work, you can list the major themes that come from that fishbone. You're going to look for duplicates, and you're going to make sure that each person on the team understands each root cause. So sometimes you have to talk those through. You know, we abbreviate those, and maybe it says failed appointment. And some people may interpret that as the patient didn't come to the appointment, or somebody else may interpret it as that the appointment didn't happen, or there was a mix-up in scheduling. So you have to make sure that you understand what each cause really means. And then you just list the problem on the flip chart, the options, and then each team member in private ranks those particular causes in order. So they're all sitting there, they've got a piece of paper, they're going to rank them in order, and then you add them up. And let me show you what that looks like. So I borrowed Moses Lake Community Health's fishbone. Thank you, Moses Lake. And you can see that there's a number of different causes here on their bones. And what I did was I took all of those causes and I listed them. So you can imagine this being on a flip chart. And all of these things are listed. These are things I pulled from the fishbone. I took anything that was duplicated. I only listed it once. I grouped them a little bit so that it says the provider lacks time. Well, there were individual entries about the provider wasn't sure about what medications to use and didn't have time to teach the patient. That there was only a 15-minute appointment, other issues, but the bottom line for that cause was that the provider lacks time. So I organized them in that way. You can do that to make it a little easier on yourself. And then I took it through what I call a feasibility review, which is what we talked about at the beginning. So you may decide that any one of these causes, for whatever reason, is not worth tackling now. So maybe, for instance, think that the patient's lack of understanding of diabetes, you think to yourself, you know, we have all of the resources we can afford right now that's trying to support patients to understand their diabetes. We don't have any more manpower to put that in right now, so we're not going to include that in this particular today to focus on. Or maybe the provider lacks internal staff, like a care manager, a certified diabetes educator, nutritionist. Again, you take that off because your boss has told you there's no money for additional staff. So we're going to cross that one out. Maybe your endocrinologist in the region just left. And so no, there are no timely referral appointments, but you can't get an endocrinologist into the region. So that's really outside of your control. So you're going to knock that one out. And maybe you notice that when you're looking at your diabetes for control, that most of those patients are cared for within your facility. It's not a coordination issue. You know that from your data. So maybe you cross this off. And of course, I'm making all of this up. So you will do this in your team as appropriate. So then you take those causes, you give them each a letter, and then you give your team members around the table or over Zoom you give them a task and you say, okay, from your perspective, rank these. What do you think is the most important? What do you think is the least important? You give the highest number to the most important, and no, you cannot put two twos. You have to rank each one with a different number. And when you do that, you come up with this. So this is what you saw right at the beginning. You see the causes down the y-axis. You see the team members across the x-axis. And the first thing you may notice is that there's a lot of variation in how team members see things. And this is always what happens. If people have different roles, they think things, probably the thing that they do may be the most important, or maybe it's something that they're sure Susie doesn't do a very good job, or Mary doesn't do a very good job, so they're going to rate that one more important. They're each coming from their own perspective. And then all you do is you tally up which one gets the highest number. And in this case, you can see that H got the most number. That means most of the staff on that team think that's the most important. And that particular cause is scheduling challenges for lab and follow-up and future labs. So if that makes sense to the team, then that would be where they would focus. So you've taken your root cause diagram with lots and lots of things on it, and you prioritized it. Maybe next they would work on a timely lab process. Oh, I meant to say, I'm just gonna say this out loud because I'm a clinician. The fasting lab, it is true that many patients with diabetes require fasting lab because it's the best way to get some of the lipid parameters. But remember, if you're trying to help a patient with A1C, they do not need to be fasting for that test. So some of us have to jump through hoops to get people fasting, and just keep in mind, if you're just working on the glycemic part, they don't need to be fasting. Anyway, so that's how you do that, particular tool. I really like this tool because it helps you sort through the reasons that you want to make the change and the reasons why it's hard to make the change. And a lot of people get hung up on that because there's always obstacles and benefits of a change. It really helps team members come from both perspectives because they participate in the whole conversation. There's not just one naysayer saying, oh, we can't do that. It's really a conversation, again, by that team who does the work to really have an honest conversation about, does this make sense to tackle or doesn't it? And it doesn't. Even if it's a root cause on your fishbone, it may not make sense to tackle that right now. So really easy to do. You draw a large T on the flip chart, write down the change that you want to think about. You want to write down the ideal state. What if things change the way that you want, if you address this root cause and things look like you wanted them to look, what would that look like? And then on one side, you have the forces that drive you toward making that change. And on the other side, those things that get in the way. And then you're going to prioritize what positive forces can you strengthen. That's one way to get toward the change. Or you can minimize those negative forces. And sometimes, just a hint, sometimes that's the easiest thing to do, is to eliminate some barriers to making the change that also pushes you toward the change in effect. So again, this is, I just took this again from Moses Lake, and I took their fishbone diagram, and I looked at a problem that providers do not optimize medications for patients with diabetes. And there are many reasons for that on the fishbone. And then I wrote that the ideal state was that our clinic provides best practice pharmaceutical care for our patients with diabetes. Again, this is stuff I made up. You may come up with something different even with the same information. And on the left-hand side, we say, well, Why do we want to provide best practice? What are the things that drive us toward that? I think mission, value-based care is coming, that providers really want to provide the best care for their patients. The clinic has invested in up-to-date and continuing medical education support so that clinicians can stay current. They want the best outcomes for their patients. They're typically want to have good grades, their report card on how they do. That's important. And perhaps you're not meeting benchmarks for incentives that if you were doing better, if your performance was a bit better, you could get some money. So maybe they're the drivers. And then there are reasons why it would be hard to make the change. So we providers are independent. We hate to be told what to do. Sometimes creating a care plan requires some time with the patient, and those 15 minutes just don't allow that. Even if you give the right medication, the patient doesn't take it and there's no support between visits. And you can see each one of these causes. I don't need to read them all, but you can see each of the causes get in the way of actually moving forward with some kind of best practice that is across the clinic. And you may look at this and you say, our mission, and we know value-based care is coming. This is so compelling that we're going to do this and we're going to address this anyway, and we're going to try to minimize some of these barriers. Or you may say, what? Our clinic director is brand new and we're in the middle of COVID and we just can't see ourselves doing this right now. It looks too hard to us right now. We're going to postpone that. Both of those are reasonable interpretations of this tool. When I look at this as a clinician, I zoom right in the middle, standardized care pathway across the clinic. I know that by creating a standardized care pathway with my clinicians, a lot of those other things would go away. So I might want to tackle that if I feel like I have the time and energy to do so. But again, it gives you a really nice look at the pros and cons. People can have a conversation about what makes sense. So this is another way to prioritize. So that's on to tool number 3. And I'll warn you that this one is a little busy to look at. But it's really important because I have been with very many people who think deeply about cause and effect. And they may come up with one thing and they say, yeah, but that depends on that, which depends on that, which depends on that. And you go round and round trying to sort through how are we going to get out of this morass of cause and effect. And this really helps us understand the relationships among the critical issues. And as Tina said, a lot of the things in your fishbone are related. You duplicated them perhaps in different bones of your fish. So there are a lot of relationships, but they're hard to visualize in your head. So this tool actually helps you visualize. It also allows you to see things even when you don't have data yet. So if you think something may be more powerful cause and you're not really sure, you don't have data, this may point it out to you. And for those of you who have a lot of things on your fishbone and you're not sure how to simplify it, this tool may well be helpful to you. So to use this, I'm going to call it an ID because it's really hard to say interrelationship diagram often. So ID, you agree on a problem statement. Again, you assemble that team of people who do the work. You write down each issue on an index card. And then most people I work with put a flip chart paper or table paper on a large conference table. Or if you're remote, you could have somebody do it on a Jamboard or a whiteboard remotely. You write down the issues and then you start with the first issue and compare it with each of the other issues that you have listed. And in each case, you look at one issue and another issue, and you decide which issue influences the other issue more strongly. So if issue A influences B more strongly, you draw an arrow from the index card with A to the index card with B. Then you would look at A versus C, then A versus D. And each time, sometimes the arrow may be pointing toward A, sometimes it may be pointing the other way. And you are not allowed to draw two-headed arrows, which means there is equal influence. You have to make a decision. And that decision can be by consensus. It doesn't have to be vote or anything egregious. Again, this is common sense stuff. Don't get hung up on it. And then you look at the incoming and outgoing arrows for each issue card. And the card with the highest number of outgoing arrows indicates the root cause or driver. And then we'll talk about the incoming arrows in a moment. So I borrowed yet another fishbone. Thank you, Catholic Charities. They also used, they included external factors. You'll see they changed the bones on their fish, which was great. And we just want to look and see how can we take these and organize them and understand their relationships a bit better. So what I did was I took their fishbone and I organized it a little bit. And if you want to see, you could just look at the prior slide. And all I did was I took the same content. There's no content different, but I organized it a little bit. So the first is that the provider didn't offer screening, and it could be that they forgot, or it could be they didn't know how to do it, so they didn't do it in the same way. And the reason that I did that, I was trying to simplify, if I could, the number of different issues that we were trying to understand the relationship. If you have a whole bunch of issues, you can imagine you're going to need a parking lot for your flip chart. So try to simplify if you possibly can before you do this exercise. But here's what it looks like. So I took each of those issues and I mapped them out, make pretend they're index cards, and each issue is lettered. And you can see that there are 8 issues, and then you draw an arrow from which issue influences the other. So for instance, if the provider did not screen, they couldn't document it, that's B, so A influences B. The provider did not screen, client did not keep the appointment. Well, if the client wasn't there, that's going to influence so that the provider couldn't screen. And you go around with each one of these, and you can see I put different colors, but you don't have to do that. I was just trying to be able to see it on the slide here. And so you go around and you create this relationship with all of the issues, and then you count. It's very simple to count the number of arrows going out from the card versus the number of arrows going in. And in this case, once you count all of these up, the number going out was the most that the system failed to send an appointment reminder. And that would be the root cause that you may want to start on, because that particular cause influences more causes than the others. Does that make sense? Okay. The other thing that you can gain from this is if all the arrows point to a particular card, in this case, provider did not screen, that's a really great thing to measure. How many times was an eligible patient not screened? That'll give you a good metric for looking at the impact of your work. If the provider more often screens patients who are eligible, you'll know you're getting somewhere with this piece. But the system failed to send appointment, that may be where you want to start. So again, this is the ID. Pretty straightforward. Again, it's all building off the work that you've already done on your fishbone and trying to figure out where to start. Okay, this is the last tool, the Pareto chart. And this is really a cool, very linear looking tool that relies on the 80-20 rule. So 80% of the problems are caused by 20% of the sources. And so this is a Pareto chart that's just a demo, and you can see along the, let me say this, the y-axis on the left is the percentage that each cause accounts for. The percentage on the right is the cumulative percentage. And then along the bottom are all of the possible causes. These would come from your fishbone diagrams. These are all the root causes we think. Now, which one of those root causes might account for most of the system trouble that we're having? It's one way to think about it. So let's dig into this one a little bit. So again, you do much the same thing. You choose the problem, you choose how you're going to look at it, you decide, and I would encourage you, don't measure it for 6 months or a year, think more like a day or a week. Think small, how long are you gonna measure? And you're actually going to count the occurrences, and you're gonna vet your hypothesis of what you think is going on by actually gathering data. And you'll be able to see the relative frequency of each of those causes as you evaluate your Pareto chart. So let's just look again at an example. So provider does not screen for depression. Well, again, that could be something that the provider forgets, or he does it and doesn't document it. And if it's not documented, it's not done. So that may be a reason. Or there may be client or system issues. So you're trying to figure out this, the provider is not on record of having screened for depression. What's wrong with this system that is causing this not to happen? Then you allow the teams to collect the data. And I would encourage you to have more than one data collection person so it doesn't fall to everyone. But you agree on how to collect the data, and you do it pretty quickly. And there's also this is actually a tool. This is a bonus tool, a check sheet. But many of you have done tallies, or you do this in your own way. You collect the data. So this team took all of those causes. They decided that they were going to track all eligible patients who were due for screening for depression. They were going to monitor all of those people eligible Monday through Friday, and they were going to count. And sometimes the provider forgot, and sometimes the client says, I don't want to do that thing. And sometimes maybe there's more than one thing that happened that was a cause in those. And you simply write them down as you see them, and you tally them up, and then you take that information and you create your chart. So there's a nice handy little thing in Excel. It's very easy to use. I can help you. I'm sure Mariah and Wendy can help you. And you just list the number of times that that comes out, and then you calculate the percentage each cause accounts for. And then just a tip, when you're doing this in Excel, if you put the percentage next to the cause, it's much easier to make your chart. That's why it's that way, just one step less. And then Excel prints out this chart. It's pretty cool. So it has the causes along the bottom. It has the frequency along the left, the cumulative percentage. And the reason that that cumulative percentage is important, if you look across at the 80 mark, you will see that it's really the first 3 problems that account for 80% of the issue in that system. So in this case, it's provider documents incorrectly, the client doesn't come to the appointment, or the screening was due, but it was missed, so it just was never done. So you don't have to focus on these others, the clients who decline, or the provider that forgets, because they're not as frequently occurring. So it really gives you an idea of which of these causes are most likely to give you more bang for the buck. So that's the Pareto chart.